Your genetics are essentially fixed at the point that you are conceived. So your genetic risk when you're born is the same as when it is later on. And then really when an illness develops, is it because there's been an environmental interaction with that, as well as being at that increased risk due to your genetics.
When you visit a new doctor, you're usually asked about your family history. Doctors use that information to help determine your genetic risk for specific diseases. But imagine if doctors could estimate your likelihood of developing a disease by analyzing your DNA. That's what polygenic risk scores are all about, and that's what we're talking about on this episode of Tomorrow's Cure, a podcast from Mayo Clinic that brings the future of medicine to the present. I'm Kathy Werzer. Thanks so much for being with us. We have two excellent guests here with us today. We're speaking with two lung disease experts who are leaders in the field of genetic epidemiology. Dr. Victor Ortega is an associate director of the Mayo Clinic Center for Individualized Medicine. He's also a pulmonologist and genomic scientist at Mayo Clinic in Phoenix, Arizona. Also joining us is Dr. Louise Wain. She is a professor of respiratory research at the University of Leicester in the UK. Professor Wain, it's a pleasure. Thanks for being with us.
Thank you. It's great to see you and meet you both.
And Dr. Ortega, it's great to see you too.
And great to be here. Thank you.
There's always a story behind why you got into a field of study or what influenced you.
My first collision with a fatal disease in a family member was asthma. So, I've always had a place in my heart for asthma and airways diseases in general. And I think that the work that we're doing is really getting into deeper insights as to why people get more severe asthma than others.
Professor, would you mind telling us how you managed to get into this field of study? What piqued your interest? Was there a person or an event?
I'd like to say there is, but actually I think it's just been a curiosity. I was just always interested in science. I got interested in data science and using computer programming to analyze data. I found it fascinating that we could use code that we have from our very beginnings to understand disease, health, how the body functions. It can tell us so much about the molecular pathways and so on in disease. And going on from that, we can also use that information to develop new drugs, because we're looking at things that go wrong that are at the very beginning of disease. We're not looking at changes in our cells that happen after the disease. We're looking at the changes in our cells that predispose us to the disease. If I'm doing something that's having some good, that's making an impact in research, and I'm putting my little bits of the puzzle into it, then that's really why I do it.
I am not sure if I did justice to describing what a polygenic risk score is. So how would you describe the concept to a patient, Dr. Ortega?
Over the past decade, we've been able to develop technologies that have given us the ability to look at entire genomes, the 3 billion letters that make up this barcode of what makes us all unique, right? And as we've done it in thousands to 100,000s, and beyond, we've found a lot of diversity in these genomes, a lot of variation. We all have unique variation. So at the same time, we've been doing these large scans of the genomes to try to understand risk for diseases that are not so rare, like asthma, chronic obstructive pulmonary disease, pulmonary fibrosis, that are not as rare. And we've come to learn that there's much initial disappointment that there's really no one singular variant in the genome that causes these common diseases. It's really a lot of different variants across the genome, across our genomes, that have weaker or milder effects on disease risk, but all together give us this increased risk. And with those discoveries, we've come to develop genetic risk scores, polygenic risk scores, where we bring together the effects or associations across variants across entire genomes into a singular score.
Is it a numerical score, by the way?
It can be expressed as a numerical score. There's two ways of looking at it. There's the amount of a genetic risk score, and then there's where you are in the population with respect to your score and how it distributes. Where are you? Are you in the lowest, 10th of the population, or the highest 10th of the 10% of the population, right? And that's how we look at that. And polygenic risk scores uses statistical models that bring together the data across many, many, many variants across the genome, whether or not they're super significantly associated or not, and brings all that data together to compile this score. And Louise, I welcome your comments on that, the specifics of that as well.
Yeah, I think that's a good point. I mean, most common diseases that we know of, including the respiratory diseases that you mentioned, including many cardiovascular diseases, including many neurodevelopmental diseases, actually have a basis in more widespread risks. So essentially, a polygenic risk score can comprise any number of genetic variants. The key thing is how you establish which variants you include to make sure that that polygenic risk score is applicable to the population, the people in which you're applying it.
So PRSs are not being used to this point in clinic, but they're out there, right? I mean, there are some private companies, direct-to-consumer companies that are using these things, and people are buying them. What would be your advice to someone who wants to buy one of these kits?
Yeah, I would say that what these kits are going to give you is a percent probability based on the genetic risk score, the polygenic risk score that's being used. These are not perfect tests. If you have a high risk score, it doesn't mean that it is certain that you will get cardiovascular disease or chronic obstructive pulmonary disease. What these tests will not give you is what to do based on the result. And for that, you will have to talk to your physician, your primary physician. And even a lot of our physicians are still trying to figure out how to decipher that data too. This is all very new. This is not stuff we were trained in medical school, and even the youngsters who are out there starting practice also have not been trained in a lot of this. It is all very new. What really needs to happen is that we take existing polygenic risk scores and we try to understand them in the appropriate clinical context to better predict disease and get a better understanding of patients with these high risk scores. How can we better manage or prevent disease by taking these polygenic risk scores and introducing them into models that we use now every day in clinical practice, trying to integrate them into models that we now understand, screening tests that we use, mammography, CT scans of the chest for lung cancer screening, bringing them together to understand polygenic risk scores in the appropriate clinical context. So then the appropriate action can be taken, and you're not just getting some report of a risk that you don't know what to do with.
I understand the concept has been around since, 2008? Something like that, when researchers created this risk score for cardiovascular disease using just a handful of genetic variants. What were they aiming for exactly?
Well, when we first started screening the whole genome to try and understand disease risk, it was really about identifying particular genes that might be faulty, and those faults might somehow contribute to why someone develops a disease. And then as we discovered more and more and more and more and more, and tens and hundreds and thousands of these variants across the genome, it became apparent that we could use it in a different way. As Dr. Ortega describes, we could actually combine that together to look at risk overall instead of individual variants. So looking at the genome in its entirety has been around for probably 15, 20 years now. But I think polygenic risk scores have become a little bit more recently than that, and maybe around 5 to 10 years ago. So it's a very new area and a very new way of looking at genetics in terms of understanding not only the causal mechanisms of disease, but also how we can use that information to understand risk.
I'm betting when you use the new information, the polygenic risk scores, layered onto an existing screening model, you mentioned lung cancer, right? Those biopsies are pretty invasive.
Yeah.
Right? So might that in the future mitigate the need to take biopsies if you take the PRS and kind of overlay it in a sense on existing screening models?
Yeah, there's two good examples, I think, of screening. One is that has not been developed yet is lung cancer screening. We do lots of CT scans in the United States every year and around the world to screen for lung cancer in people that are at risk would have certain pack your smoking histories, and after a certain age, you're eligible for CT scan screening. And what we find are these nodules. And we find a lot of them. And a lot of people get biopsies. And a lot of those biopsies are negative. Of course, we do find lung cancer, and it is a life-saving screening tool, but we do a lot of biopsies to save a smaller proportion of people's lives.
There's a lot of stress with those biopsies, by the way.
Yeah, and it's stressful. And some people don't get biopsied immediately. Some people have a small nodule, and they say, okay, well, we're going to do a CT scan in a few months from now, in another few months. So there's essentially this waiting and this agony of having this. When we see a nodule, the models that we use to predict whether you do a biopsy or not, or if you wait and do more CT scans, is really based on models that have existed for decades, very old models. What if we took a polygenic risk score for lung lung cancer. Or you can combine several polygenic risk scores for lung cancer into a meta-PRS or a meta-polygenic risk score, and then combine it with our traditional aged risk factors, bring it together, and then say, hey, you have a high risk of lung cancer based on your polygenic risk score integrated model. Maybe we should do the biopsy earlier, and then you intercept the cancer earlier. Or, it's very low risk, probably not cancer. So why don't we wait a little bit and then the nodules stay stable and you're good.
And of course, in the UK, Professor, you have the UK Biobank that you can use, which is quite a robust data set.
Yeah, I mean, the UK Biobank, that's been transformative in terms of genetic research. It was the first huge general population cohort with linked genetic data, with linked healthcare records, with loads of variables, questionnaires. It's giddying the amount of data that's in there, and it's been used across all different disease areas. You could do a genetic study of anything, any of the traits that are in there, and develop a polygenic risk score using the UK Biobank. But even though it's 500,000 people, it's only 500,000 people. It's not representative of the UK population in its entirety. It has a white ancestry bias. There's a certain demographic bias to it. We still need to make sure we've got the resources that are more representative of the population, that we're capturing the populations. There's new efforts underway in the UK. So we have something called Our Future Health, which will capture data and genetic data from 5 million people, which I think will be the next step change in terms of genetic research, at least in the UK. There are efforts in the US. So things like the All of Us study, which is much more diverse than UK Biobank. It has a very high proportion of individuals of African American ancestry. So I think things are certainly developing. I think Biobank has been a real catalyst for developing a lot of the polygenic risk score work that's out there. But I think there's a lot to be done in terms of the generalizability and making sure that we're capturing that. So yeah, Biobank's been brilliant for that. But I think it's certainly created that fantastic foundation. But there's a lot more to do, and that's why much more deep and complex data sets are needed to drive it forwards.
And this is used to determine lifetime risk. Would that be right?
Yes.
Okay, just to be clear about that.
The thing to consider with a polygenic risk score is that actually it does reflect a risk factor that's been there throughout your life. Your genetics are essentially fixed at the point that you are conceived. They don't change materially over your lifetime. So your genetic risk when you're born is the same as when it is later on. And then really when an illness develops, is it because there's been an environmental interaction with that, as well as being at that increased risk due to your genetics.
Yeah. Well, and while there is a lot of enthusiasm about the predictive potential with polygenic risk scores, they're not perfect. As a matter of fact, they're far from perfect. Even when you bring together 500,000 people to do a lung function polygenic risk score, or what you're essentially finding is that what we find really only really explains 15% of the heritability of the trait. There's a missing heritability issue with genome-wide studies in general and in the development of polygenic risk scores, and that is because of the importance of the environment, among other factors. But we'll talk about the environment. I mean, the environment is dynamic and it gets at the exposome.
Right, exactly. Your exposures, right, over your lifetime?
Our genomes are exposed to different environmental factors that alter the regulation of the genes in ways that we're not seeing in the genetic code, like methylation of DNA or changes in how it's folded. And without getting too technical, but our genomes respond to the environment. And that response is not captured in these polygenic risk scores. And our environmental exposures vary. Your environmental exposure history is going to be very different from mine. That's just how it is.
And Professor Wain, you've been doing studies in terms of the effects of the environment, right?
Yeah, it's a really important thing to consider. And I think that's why when we think about polygenic risk scores, we need to not consider them as risk in isolation, but make sure that other factors are captured. Some of the work that we've been doing on COPD with risk scores, that we've tried to see what that would look like if we included environmental interactions. So most people will know that people who smoke are at the highest risk of COPD. If you don't consider smoking and you look at the polygenic risk score for COPD, and this is work that Vic and I have done together, individuals who are in the highest 10% of the population in terms of their genetic risk for bad lung function are 5 times more likely to develop COPD than those that are in the lowest decile. But if you put that then in the context of people who smoke, what that means is that people who smoke and have the lowest genetic risk have around a 1 in 5 chance of developing COPD, which is pretty high. But then if you look at people in that highest risk score decile, so in the highest 10%, they have a more than 80% chance of developing COPD. And that's when you combine their genetic risk with their smoking behavior as well.
Would you like to make a comment on this, Dr. Ortega?
Yeah, no, I mean, tobacco smoke is an incredible example. And we're starting to understand the interactions of tobacco smoke exposure on risk of COPD, because COPD, chronic obstructive pulmonary disease, is actually a disease defined by a lung function impairment. But some people have COPD who've never smoked. And it's because of differences in how the lungs have developed over the lifespan and environmental exposures that precede the decision, even before the decision to smoke or not smoke. Nutritional, environmental pollution, and even among smokers with COPD, exposure to PM 2.5, ozone, different environmental exposures have been associated with more severe COPD. And that really gets at social determinants of health, environmental factors, where you've lived. The exposome is highly complex, and I'm not sure how we're going to capture that in a bottle. I just, that is such the term exposome is such a general term, and I think that it's a field in evolution.
It is. And we talked about that last season too.
Yeah.
But it's fascinating. So I want to go back to something you said, Dr. Ortega, and then maybe Professor Wain, could you please talk about this too, is that PRSs are not perfect, right? And there are some limitations because they've been developed using mostly Eurocentric genetic databases, right? So how much is the polygenic risk scores predictive power then reduced in more diverse populations? I'll start with Professor Wain.
Now, you're absolutely right, Kathy, and I think that this is probably one of the biggest limitations that's preventing polygenic risk scores from really moving forwards. Most risk scores have been developed in populations that have been limited, so limited to people of a very specific ancestry, for example, white ancestry. And as a global population, we're very different. We vary considerably from one population to another, and we're not discrete populations either. So as soon as we develop a risk score in one particular population, its ability to predict in a different population starts to drop off. And that means that we need to make sure that the polygenic risk scores are developed across different and very diverse ancestries, and that they're appropriately tested to make sure that they'll be equitable if they do, as and when they do come into clinical use.
So I wonder, how then might we include more data from a greater range of ethnic backgrounds to try to mitigate some of this?
It's all about inclusion. It's really about trying to fill in that missing data. The African ancestry is the most ancient of ancestries. And that more ancient African ancestry has more rare variants. So the recent admixture of all these ancestries results in the different ethnic and racial groups that we have today that have these diverse ancestral backgrounds. But when you talk about doing these large-scale genetic studies in primarily non-Hispanic whites, but for the most part excluded the most diverse background ancestry that we have, among others. So you run into, the result is genetic polygenic risk scores that have poorer predictability in more ancestrally diverse populations.
I wonder then, given what we know, how might doctors effectively then communicate the results of PRSs based upon these limitations? Again, you've said, Doctor, that they're not perfect, but, it's a tool to use, right? Would a significant challenge perhaps be that once a person gets their PRS score for, say, asthma, something like that, is the challenge then coming up with an effective disease prevention strategy based on the results?
I think the application of polygenic risk scores is very context dependent in the context of the disease you're dealing with. Asthma is an example of a disease that we probably will have a very hard time preventing, because we're really not going to prevent a baby from getting a virus or other insults that happen during the lifespan that result in asthma. But diseases like chronic obstructive pulmonary disease, for example, if you had a high risk you may tell somebody, hey, look, you may not want to pick up that cigarette. Asthma is an example of a disease that's caused by multiple genes.
With some environmental factors, obviously.
Environmental factors, but the thing about asthma, so everything, like I said, it's all context dependent. So asthma is a disease that's actually very heterogeneous. There's allergic asthma, and then there's asthma that's not allergic, that's driven by other kinds of inflammation. And that understanding has actually driven the therapies that we have for asthma today. Very promising biologic therapies that target very specific molecules that have been a game changer for management of asthma, severe asthma, patients with asthma who don't respond to common drugs. But when we actually looked at these biologic drugs, they were largely disappointing. But when we actually started isolating different blood biomarker, we found that the drug actually was quite effective in patients with higher blood cells. And there's evolving approaches that Louise's group is doing, that we're starting to do, where we can take polygenic risk scores, take asthma and the different features of asthma, and do a reverse GWAS, do some partitioning, and actually break the polygenic risk score into different parts that reflect the different kinds of asthma you can have. This is still a work in very early stages, but I'd like Louise to comment, but in very early stages, yeah.
Professor Wain, would you like to comment on that? Sounds pretty interesting.
Yeah, I think it really is. I mean, there's two ways that we can break that down. We can break the population down based on the biomarkers and generate the polygenic risk scores to then identify, without having to measure the biomarkers, who might be the most responsive. The other thing that we can do that's really new is partition the general risk score even more to try and understand which particular molecular pathways might be driving those as well. And I think, as Victor's alluded to, these are quite early in development, but are potentially really, really important in the future. As Victor's already described, we could use this to improve diagnosis, where somebody's already presenting with the disease, but they need a specific diagnosis in order to access the medicines that are going to work for them. So we can use it for that.
Dr. Ortega, I remember hearing about your grandmother as I was prepping for our conversation, and your grandma, I know, when you were young, died of complications of asthma. So in the context of our conversation here today, I'm kind of curious whether you think your grandmother's treatment or outcome could have been different if polygenic risk scores would have been available back then.
I don't know if polygenic risk scores will ever prevent asthma, at least soon, but maybe understand why some people have more severe forms of asthma than others when you actually break the polygenic risk score down to understand the different types of asthma that exist. And my grandmother was Puerto Rican, and Puerto Ricans have the most severe asthma of any ethnic group really in the world. I mean, they're the most severe asthmatics, yeah. Yeah, and because to die of asthma is actually fairly rare. But to see that in my family, to have a mother with asthma as well, I went into this work to really try to understand, what happened and why do some people get more severe forms of disease than others? It's a very different question than what polygenic risk scores have been answering up until now. Polygenic risk scores have been risk of disease.
Can we talk about what patients might think of this in due time if it gets into clinic? I wonder about patients who just would not want to know what their PRS score would be. And I know you both are obviously very involved in this, but I'm curious, and I know, Professor, you don't see patients, but I wonder how do you try to convince someone that this would be actually a good bit of information to have?
I guess, again, it goes back to if there's something that they could do about it. We had the similar kind of discussions around some rare diseases and Mendelian diseases. If you carry a particular variant and you're going to get very ill, but there's nothing we can do about it, do you want to know about it? Some people, will want to know what if they've got a high risk of cardiovascular disease. They might be open to lifestyle changes, and that's great. But many people won't be. They won't want to be told that, they've got to make lifestyle changes to reduce their risk. I think it's about communication, as Vic described earlier for idiopathic pulmonary fibrosis, where part of the diagnosis is actually having a piece of lung removed to have a look at it. And that's really quite risky. But if you could convince them that actually, if we can look at your genetics, we could avoid that and maybe accelerate you towards the right treatment that will work for you. So again, it's all about communicating, and it's all about the context of the disease or the illness that we're looking at and the population and the polygenic risk score that we have. Yeah,
I think the less likely there's something you can do about the result, the more likely a patient will probably not want to do it. And I actually, that experience is largely from what I do with Mendelian diseases.
Kind of rare diseases.
Yeah, and then they're rare. Yeah, they're rare, uncommon diseases. But once again, it's a singular variant with a very strong effect that will cause it with a pattern that you can see across siblings, grandparent to parent to child.
And by the way, we should say for listeners, I've heard the word Mendelian used a few times in our conversation. We should probably define that. Professor, could you do that for us?
So it's essentially that scenario where you have a gene mutation that if you have one or two copies of that gene mutation from your parents, you will, with almost certainty, develop that disease in your lifetime if there's no intervention or there's no other factors that influence that.
As an airways doctor, I take care of people with different airways diseases, and that has included cystic fibrosis, bronchiectasis, and early emphysema, COPD, and alpha-1 antitrypsin deficiency. So those are Mendelian, and I have to have conversations with patients about genetic testing, and that really is an important thing about genetics. It really takes you really do have to talk to the patient about the test you're going to do and the implications of the testing. And what you will do if you find something. It is really going to be our due diligence to really try to understand what is the clinical impact of understanding what polygenic risk score you have. Otherwise, we're just giving statistics that can cause undue anxiety.
What excites you both about what you do, by the way? I mean, you both are on the cutting edge of using genomics to help so many people. What about that excites you, Professor?
Knowing that the research that I do as a consequence of that could one day be used by doctors to actually change the way patients are treated for the better and improve quality of life, I think is really important. I have family members with diseases, I have family members who sadly passed away, and I'm always keen to try and find ways that help to find ways where that could have been avoided or delayed, or at least quality of life could have been improved. So,
and Dr. Ortega?
I think that one day we're going to go into a doctor's office, get our heart rate, blood pressure, and our whole genome, if it wasn't collected at the time we were born. I believe that is going to be the future here. And I feel like what work that people like Louise and myself are doing are bringing us closer to that future where we can really understand and intercept disease and really treat the patient as the center of the healthcare paradigm as the Mayo brothers had envisioned it. Right now, it seems like a moonshot, but once there was somebody who did step on the moon. But it's one step at a time, and that's what keeps me going, taking that next step.
Wow. Well, Dr. Ortega, and of course, Professor Wain in the UK, thank you so much for joining us. It was a really good conversation. We appreciate it. Thank you.
Thanks.
Well, thank you very much, Kathy.
Yeah, thank you, Kathy.
Tomorrow's Cure is a co-production of Mayo Clinic and PRX. Our producers are Deborah Balthazar and David Newtown. The show is edited by Genevieve Sponsler. Our sound engineer is Tommy Bazarian. Our theme was composed and produced by Terrence Bernardo. Tony Carlson is our production manager, and our executive producer is Jocelyn Gonzalez. Special thanks to Preston Spire for audiovisual production support. Be sure to follow Tomorrow's Cure wherever you get your podcasts. I'm your host, Kathy Wurzer. Thank you so much for listening.